Kalma, baby kalma. Huwag mo naman akong bigyan ng dahilan para tabihan ka. Kalma. Kita at habang tumatama yung vodka, mas lalo ka bang tumitindi. Huwag mo naman nangasan ng sobra, hindi ako makakaindi. At wala akong pakialam kung merong makakita, di na mangyayari muli. Di ako papayag nang di ka mauuwi. Pag nagpalagabog na si ate, sobrang swabe, ang salbahe. Tignan mo siya kung paano gumiling, para palaban ang atake. At malakang na lang ang kailangan, tapos na kagad ang usapan. Man, I wanna see her booty go left cheek, right cheek. I wanna see her booty go Morena!
Hinahanap ko, hinahanap ko.
Nuclear magnetic resonance was first observed in the late 1930s. The public's negative interpretation of the word nuclear led to the term's removal. The first whole-body MRI scanner was built by American physician and scientist Raymond Damadian, who also gave it the nickname Indomitable. Damadian discovered that magnetic resonance imaging could be utilized for medical diagnostics. MRIs are often misunderstood, and some myths say that MRI scans expose patients to harmful radiation. To correct these misconceptions, an MRI exam produces detailed images of internal structure in a patient's body without any exposure to radiation. With the use of magnetic resonance imaging, doctors are now able to accurately diagnose a wide range of conditions, making it an essential component of modern medicine. Good morning, everyone, and thank you so much for tuning in. Welcome to this webinar entitled Looking Good, Am I Right? I am John Paul Oyer from the BSRT3A, and I will be your host for today. Over the course of this webinar, we will be talking about magnetic resonance imaging, common MRI findings, and MRI procedures. But before we get started, there are just a couple of things I want to tell you so you can get the most of this webinar. As we go along, let me remind everyone to please mute your respective microphones. Secondly, we will gladly entertain questions about the discussion. Please feel free to post them in the chat box at the bottom of the screen, the group chat, or the comment section in the live stream, which will be addressed by the speakers during the open forum session. Lastly, if you have time at the end of the webinar, we'd be so grateful if you'd fill out the evaluation form for the issuance of a certificate of participation. Your feedbacks will help us improve things for you in the future. And now that everyone is ready, let's get started. To officially start our program, may we request everyone to feel the presence of the Lord for our opening prayer to be led by Miss Kyla Balanday. This will be followed by the singing of the Philippine National Anthem and UEP hymn through audiovisual presentation.
Let us bow our head and put ourselves in the holiness of God the Father, the Son, and the Holy Spirit. Dear Almighty and ever-loving God, we glorify and thank you thee your name. You have showered us with so much blessings, and your presence continuously remind us of your faithfulness and guidance. We humbly ask you to shower our speakers today of your greatness, inspiration, so that they may share the most of their knowledge, heart and soul to their respective topics. May we also absorb the invaluable knowledge, experiences, and put into practice what we may learn today. Your infinite blessing would mean the success of this seminar. May we be a living witnesses of your genuine love through the enactment of the knowledge acquired through this activity. We ask this in the name of Jesus Christ, our Lord and Savior. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang magiliw, pero sa sinanganan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, kuya ka ng magiting, sa manluluping, di ka pasisigil, sa nagagang tutok sa simoy at sa langit ng pangaw, ay hinagang tula, kawin sa pagkayang minamahal. Ang isang ng matawad mo'y tagumpay na nagtitindig, ang bituin at araw niya kailan pa may di magtitindig. Luman ang araw ng warhabit pagsinta, buhay langit sa piling mo. Ang inigaya ng pagkay mga api, ang mamatay ng dahil sa'yo.
Let us sing to you, O you EP. Sing the blue of your sea, the green of your mountains, the grain in your fields, the harvest in your hooves. Let us sing to you, dear UEP. Sing of your children fair, the knowledge you share, the values instill, the service you render. Onward forevermore, UEP, God's grace be upon you. His mighty hand protect and guide you as you face challenges. Turn them to opportunities and your founder's dreams pursue. So we sing this hymn to you of praise and gratitude. Beloved alma mater, keep your blue and gold soaring. Our fount of wisdom, joy and hope, and silent loyalty we do pledge. And silent loyalty we do pledge.
Good morning once again. We extend our heartfelt thanks for the presence of our highly respected Professor Rangel L. Estunilo, MSRT, and College of Nursing and Allied Health Sciences Research Coordinator, Professor Christine Camille Habines Sosaya, MSRT, or BSRT Program Chair, Professor Remy Balyata, RRT, Professor Rachel Capuno, RRT, Professor Dermalin Malubago, MSRT, RM. Dr. Mark Seymour Mabalatan, MD, FPCR, FCT, MRI, SP. Donald Ian Abablit, RRT, and to the BSRT students. Once again, good morning, and we are honored to have your presence here today. At this juncture, to formally kick off our webinar, I would like to give the virtual floor to Professor Jimul Fred Kapukyan to give his welcoming remarks. A virtual applause, please.
Good morning, everyone. Am I audible?
Yes, sir.
Good morning, everyone, once again, and welcome to this webinar. I am honored to be here today, welcoming all of you to this event, to the University President, Dr. Sherry Ayutra, Dean of the College of Nursing and Allied Health Sciences, Dr. Sara De Lorino, College Research and BSRT Intern Coordinator, Professor Ronjel Estonilo, BSRT Program Chair, Professor Christine Camille Javines, our esteemed BSRT faculty members, Sir Rachel Capuno, Sir Remy Baleta, and Ma'am Dermalin Malubago, our resource speakers who will share their knowledge and expertise, Dr. Mark Simo Mabalatan and Sir Donald Ayan Nabablit, our hosts, selected BSRT3 students, and of course, all of these students from different schools, both in Zoom and FB Live, who have made an effort to attend today's webinar. Once again, welcome to this webinar entitled Looking Good M-R-rIght. And I guess I am the best choice to welcome you to this event. Joke lang. I hope every one of you right now not only feeling good, but also looking good all throughout the webinar. This webinar is perfect opportunity for us as we can hear from experts in the field and learn about new and exciting topics about the M-R-I. To the students here today, especially the BSRT3 students, I want to remind you to make the most of this opportunity. So please listen during the presentation. This is a big help to expand our knowledge and improve our understanding to our subject RT323, the M-R-I. A special welcome is also extended to the resource speakers joining us today. We appreciate your willingness to share your knowledge and expertise, and I am confident that everyone here will gain something from your presentation. I would like to thank all of you for being here today, and I hope that you will make the most of this opportunity to learn and grow in the field of radiology. Thank you very much. Good day and God bless.
Thank you, Sir Jimwell, for your warm and heartfelt welcome speech. And now, may I call on Professor Rachel Capuno for the introduction of our participants. And now may I call on Professor Rachel Capuno for the introduction of our participants.
Hi, good morning, everyone. So allow me to welcome each and every one of you to our webinar for this day. So let's start with the young hopeful of our BSRT Level 1 student from the University of Eastern Philippines. Guys, turn on your camera and make some noise. BSRT Level 1.
Yay!
Wala yung BSRT Level 1. So let us have the BSRT Level 2 of the University of Eastern Philippines. Turn on your camera, guys, and make some noise. Ay, baka nasa ano sila, nasa Facebook Live because
Oo,
fully
baka
booked yung
sakali.
Zoom natin ngayon. So, thank you everyone for joining us. Maraming salamat po. So, napaka-overwhelming talaga ng presence ng mga estudyante namin at ng ibang colleges, of course. And let us welcome the BSRT Level 3 of the University of Eastern Philippines. Turn on your camera and make some noise. Hindi pala makakapag-make ng noise. Ano kasi naka-mute. Sir,
Nakamute. Hello, oo, nakamute yung
pala sila.
nag-mute ng host.
Morning, sir.
Action na
Ayun,
lang.
Good morning, sir.
Good morning, sir. Good morning, sir.
So this is our BSRT Level 3, both Section A and B. Di ba? Ang gaganda nila. Sing ganda ng
Ganda ni Sir Rachel.
Sing ganda at sing gwapo namin ni Sir Rochelle. Char. So yan po ang
Char.
beauty namin. So punta na tayo sa BSRT Level 4. Ready na ba ang BSRT Level 4? So let's start with the list coming from the affiliated hospitals. Simulan natin sa pinakamalayo at sa mga mapagmahal dahil doon sila naka-assign sa Philippine Heart Center of the Philippines. Yung mga intern natin dyan sa Philippine Heart Center. Magpakita kayo. Wow! Ang ganda. So the next is the um, Philippine Orthopedic Center of the Philippines. Nasaan na kayo? Oh, wow. And we also have the interns from Jose Reyes Memorial Medical Center. Mga freshness
Ayun,
over.
nandun sila. Ato pa, Jean.
Kasi ang tagal na nila doon sa Manila. So next will be from Tacloban naman tayo. Punta naman tayo ng Visayas. So nakita niyo po yung mga interns namin sa Manila. Ganyan po sila kagaganda at kagagwapo. So next would be the interns from Eastern Visayas Medical Center. Nasaan na kayo, guys? So EVMC interns, where are you? Baka hindi rin sila nakapasok. Baka nandun sa Facebook Live. Okay, so let's go with the Divine World Hospital. Yung mga taga-Divine, nandiyan na ba kayo? Nandoon sila, nagko-comment lang. Okay, punta na tayo sa pinakamalapit sa Samar. Starting with the Samar Provincial Hospital. Show up guys, magpakita kayo sa cam. Wow. Yan sila. So, the next would be from the St. Camillus Hospital. Mga interns natin sa St. Camillus. So, we also have ito ang pinakamalapit na talaga sa university, Northern Samar Provincial Hospital interns. Nasaan na kayo, guys? Okay. So, nandun sila. So, we would like also to acknowledge our guests coming from different colleges, starting with yung pinakamalapit sa amin, yung pinaka-sister-sisteran namin na college dito sa Visayas. We have the Holy Infant College of Tacloban. Welcome, everyone! And, syempre, yung friendship din namin na college, which is the Lorma Colleges. Nagpakita kayo, guys.
No.
Thank you for joining us. Maraming salamat po. And of course, yung guest speaker po namin ngayong araw na ito, si Sir Donald po, Nabablit. Welcome po, sir. Welcome once again. And si Dr. Seymour. Thank you po for being us this morning. And of course, this is made possible through the effort of our highly esteemed faculty, starting with the program chair, Ma'am Camille Cavines, and our research coordinator of the college, Sir Ronjal Sunilo, and our
Hello,
SIPP
morning.
coordinator, Ma'am Darmalin Malabago, and of course, our very dear Sir Remy Balyata, and with the efforts of the BSRT Level 3. Thank you, everyone. Have a great weekend, and I hope you will learn a lot with this webinar this morning.
Thank you, Sir Rachel Capuno. At this juncture, to add some excitement to our webinar today, we will be entertained by an intermission number from the BSRT 3A student. Let's give them a round of virtual applause, please. Thank you, Miss Betty, for that fantastic performance. As we progress further, it is our pleasure to have an insightful session led by our distinguished speaker. May I now invite Professor Christine Camille Avina Sosaya to introduce and present our first guest speaker for today.
A pleasant morning to everyone. So it is my honor to introduce our guest speaker for today's webinar. Our first guest speaker for today's webinar, Dr. Mark Seymour Mabalatan, a renowned radiologist and a true luminary in the field of medical imaging. Allow me to share to everyone a glimpse of his remarkable journey. Dr. Mabalatan is a fellow of the Philippine College of Radiology and holds a dual specialization in CT and MRI imaging. A member of the CT MRI Society of the Philippines, he continues to contribute significantly to the advancement of diagnostic imaging. Beyond his professional achievements, Dr. Mabalatan is a multifaceted individual. So when he is not deciphering intricate scans, you might find him strumming his guitar, meticulously assembling model kits, or waving beautiful poetry. Dr. Mabalatan is an active consultant at the Vicente Soto Memorial Medical Center since 2021. Prior to that, he also served as a fellow in CT MRI at Chonghua Hospital, and during his residency at the same institution, he performed and interpreted a wide range of routine imaging modalities, including X-rays, CT scans, MRIs, and ultrasound. His commitment extended beyond diagnostics as he trained and supervised junior residents, interns, and postgraduate interns. Dr. Mabalatan's thirst for knowledge led him to attend numerous lectures and conferences that are relevant to his chosen specialty. Dr. Mabalatan's credentials speaks volume. An associate member of the Philippine Society of Neuroradiology and Head and Neck Radiology since May of 2022, and a proud recipient of the Philippine Board of CT-MRI certification in May of 2021. Notably, he also conquered the Philippine Board of Radiology certification exam in January of year 2020. Dr. Mabalatan's educational journey began at Cebu Doctors University, where he earned his Doctor of Medicine degree, and prior to that, he completed his Bachelor of Science in Medical Technology at the same institution. His scholarly contributions are equally impressive. In 2020, he authored a study titled Correlation of Tumor Size in Contrast-Enhanced CT Scan of the Liver with Serum Alpha Fetoprotein Levels in Filipino patients diagnosed with hepatocellular carcinoma in Chongwa Hospital. Additionally, in 2019, he investigated the comparison of liver span among different ages of patients diagnosed with ultrasound findings in cystomiasis in Chongwa Hospital. So, ladies and gentlemen, please join me in welcoming our first guest speaker, Dr. Mark Seymour Mabalatan, a beacon of expertise, passion, and innovation in the realm of radiology. May his insights today promise to enlighten and inspire us all. So, thank you.
Bumoto? Ça va bien? Good morning. That was French for good morning and is everything well? Thank you for your very kind introduction. I don't think I can live up to that, but I'll try anyway. College, most of the viewers here are in college. It was ages ago for me. I hope you cling on to your youth while you can before the reality of adulthood sets in. You will be admired for choosing RadTech as your course. Frankly, we are short of RadTechs in this country, and I hope upon graduation you can fill the gap. So let's get to down to business. MRI is often daunting. It's one of those modalities which not all of you might be exposed because number one, MRI is an expensive machine. So you'll only probably encounter that in tertiary hospitals. Number two, MRI takes time to scan. We've got a lot of sequences. We've got a lot of things to look out for. You've got to know your T1 from your T2, from your T2 to your diffusion weighted. There's a lot of things to absorb, which even I cannot memorize. So I hope this short lecture of mine can enlighten you when you start your practice as a rad tech and you have the fortune to be in a hospital with an MRI. So I hope I can enlighten you even a bit. So I shall commence. Are my slides visible?
Yes, Doc.
Okay.
Yes, Doc.
Sige, I will start. Among the requests on hospital, MRI is certainly the most commonly requested scan. Why? Sometimes CT scan cannot be enough. Sometimes your CT will not reveal what your doctor will be looking for. Why? Because sometimes CT cannot detect subtle lesions. So if you want more problem-solving capability, you proceed to MRI. MRI can detect more subtle lesions in a superior soft tissue contrast and resolution. And of course, one of its top advantages is the early detection of cerebrovascular disease. So early detection of strokes can help the patient have a better outcome. One moment. Okay, forward. So these are the basic sequences you have to look out for in an MRI. I hope I'm not talking too fast. All right. T1 weightage. So we have your short T1 and TR and TE. T1 is what I use to assess for the anatomy of the brain because it follows the natural color, so to speak, because gray matter is gray and white matter is white, still gray. You can clearly see in this image a slice, an actual slice of the cerebrum, the supratentorial brain. You can clearly see the frontal lobes, the superficial and deep white matter, the caudate nuclei, the basal ganglia, the thalamus, and the corpus callosum. T1 is important because, like I said, the brain has an exquisite anatomy, and if you want to look for subtle or frank differences in anatomy in the brain, you can always check T1 because there might be something wrong in your gray matter and white matter. And the thing about the brain is it thrives on symmetry, meaning you only need to compare between both hemispheres because both of them have to be very identical, so to speak. It's also sensitive for detection of blood, fat, and melanin because these substances have T1 shortening. So if it's bright or hyper intense on T1, you might narrow your differential, and you can also ask your radiologist over there what they think. Moving on to T2 weighted. T2 is useful for fluid because fluid will be very bright and you can see if there's an excess of fluid, meaning there must be edema, hydrocephalus. However, many lesions, for example, masses, abscesses, can also show abnormal T2 signal. We also use T2 for the assessment of myelination because your white matter as from childhood until adulthood is ever evolving. So we have landmarks about temporal landmarks on which to gauge the white matter maturity. Okay. Flare is a cousin of T2. It's still T2 weighted. However, we suppress the fluid. So fluid becomes dark signal. It's also sensitive for the detection of extra fluid because extra fluid, meaning edema or things that will cross the blood-brain barrier, will present as bright signal. Only normal CSF will persist as a dark signal. It's also sensitive for blood. DWI, diffusion weighted imaging, that's one of your best friends for the rad tech and the radiologist because DWI is the go-to sequence if you want to look for stroke, specifically ischemic stroke. Why? Because DWI can detect stroke as early as 6 hours because that will be the time when there will be diminished movement of water molecules, if you remember the Brownian movement principle, because of infarction. So if I were you, if your patient that you've scanned for MRI has signs of stroke, I'd get the DWI first, and once you get it, you refer to the radiologist. They might be able to detect an early stroke. We have different B values. Usually there's B400, B800, B1000. In our institution, I look at the B1000 because higher B values means better sensitivity for diffusion restriction. And you have to avoid the T2 shine through artifact. And how to correlate your DWI? You look at your ADC. ADC is inverse of DWI, meaning anything that is bright signal on DWI, if it's true infarction, it should be it should be dark signal in ADC, meaning inverse relationship. Because if the lesion you see in DWI that is bright, but in ADC is also bright, that's the T2 shine through phenomenon. So remember, you cannot assess a DWI without looking at the ADC. For certain materials, the paramagnetic and ferromagnetic, if you're looking for blood calcifications, we have two sequences that we use, the susceptibility weighted imaging and gradient recall echo. These these sequences will show you if there are areas of hemosiderin deposits from blood products. But the thing is, it might not be easy to differentiate this from calcium. Keep note that as we age, certain parts of our body will accumulate calcium deposits normally. For example, in the basal ganglia. So if you're in doubt, if what you see shows magnetic susceptibility in SWI or GRE, and if you're not sure if it's blood or calcification, also refer to T1, because if you read the table of the natural degradation of blood products, you might see high signal on T1, which indicates a subacute hemorrhage. And of course, if it wasn't hemorrhage and its calcification, you might also need to look at a CT scan, because CT scan attenuations of calcifications will have much higher value in their Hounsfield compared to blood, which is around 60 to 80, and calcifications can reach several hundreds to thousands. Um, Unlike CT scan where it's one and done, right? You just scan the actual, then you just do a 3D reconstruction. MRI is several parts of a greater whole. Remember that one sequence cannot tell you the whole story. So that's why we have a dedicated protocol, a standard protocol of which you have to acquire to get a proper diagnosis and to make sure your patient gets the best neurological assessment and care possible. Just go with normal variants which you might encounter, which might be mistaken for diseases, but they're just actually normal. Here is a T2 image of a cavum septum pellucidum. Normally, this is present in the fetus and newborns, and it gradually closes before they mature. But in some people, they never close. You see this as the the cavum septum pellucidum is a fluid filled structure within the two leaves of septum pellucidum, and if it extends beyond the fornix, it's called cavum septum pellucidum et virgae, normal variant. Another one is velum interpositum, which is the structure in between the atria of both lateral ventricles. It is triangular in shape and is also filled with cerebrospinal fluid. So its signal should be bright on T2 and suppressed with flare. As mentioned above, as we age, parts of our brain will normally calcify: basal ganglia, choroid plexus, which produces cerebrospinal fluid, and pineal gland. So these are best seen on susceptibility weighted imaging and gradient recall echo, as mentioned above. So don't mistake this for a lesion, especially if they look symmetrical. Remember, symmetry is key in the brain. And in some people, your ventricular system doesn't have the same size. You will notice that one might be larger than the other, but this is commonly a normal finding. Nothing to be afraid of, especially if there are no signs of hydrocephalus or signal changes in the periventricular white matter. For pathologic findings that you must be aware of in your practice, of course, bread and butter of MRI, we have to look for stroke. The brain has several vascular territories. You might want to remember that the brain's major circulatory system is called the circle of Willis, which involves the anterior cerebral artery, the internal carotid artery, the posterior cerebral artery, and their communicating artery. So what you see here are representative parts of the brain supplied by what vessels. So ischemic stroke happens when one of these vessels is occluded. It might be from a clot, most commonly, or it might even be from hypoperfusion, meaning there's not enough blood to supply the brain. And depending on what artery will be involved, that territory will have a stroke. So ischemic stroke infarction has a well-documented chronological order with apparent changes in signal and density depending on the morbidity as it evolves. So as I stated, on as early as 6 hours, we can already see an infarction going on. So early detection for better management of the patient. You see here, to your left is a diffusion weighted imaging, and to your right is ADC. On the DWI sequence, you will see high signal, meaning restricted diffusion in the left cerebral hemisphere, approximately corresponding to the territory of the left middle cerebral artery. So remember, if you look at an actual, to your left is actually the right side, and to your right is the left side, because we're looking at the patient from down up. This is an infarction because it's a true infarction because it shows corresponding low signal on the ADC map. It's not T2 shine through. Acute infarcts also have signal changes on T1 and T2 and flare. On T1, when they're acute, they present as low to intermediate signal. And on flare, T2 flare, they are already high signal. You can see that there is mass effect, meaning compression or effacement of adjacent sulci, subarachnoid spaces. And if it's really big, it can even cause midline shift. Subacute infarct happens after a week or so. So eventually the infarct will have slowly decreasing signal on DWI, and it becomes more circumscribed on T1 and T2. This is the stage where it is most prone to hemorrhagic conversion. So you might see blooming artifacts on GRE SWI. And one of their unique characteristics is that subacute infarcts show contrast enhancement. To your right is an infarct in the left lentiform nucleus showing enhancement. And if you do a gradient recall echo to your left, it shows foci of magnetic susceptibility, suggestive of hemorrhagic conversion. Eventually, as the infarct heals, it heals through encephalomalacia. So there will be an area of liquefactive necrosis, which corresponds to the core of the infarct, which then fills with CSF because it's now a space. Most encephalomalacic changes are surrounded by gliosis. So if you look at your flare image in the middle, you can see a chronic infarct in the left cerebral hemisphere and surrounded by a rim of high signal. This high signal corresponds to gliosis. So you can also see widening of the ventricle near the infarct as well as the subarachnoid spaces. This is due to volume loss. Chronic infarcts do not restrict on DWI. The other kind of stroke is hemorrhage, which is a bit confusing because hemorrhage might look similar to masses on MRI. The first clue you have to look at is, of course, your susceptibility weighted imaging, because as hemoglobin contains iron, it will show us blooming artifacts on GRE SWI. So I have prepared some representative images to show the evolution of blood. So remember, in each stage of a hemorrhage, you start with oxyhemoglobin and it degrades eventually, which contributes to its signal changes. Now, it's a bit harder to memorize blood, but as a nice tip, most people who have MRI might not even have acute hemorrhages already, might have already subacute, and uh, a hack is you look at T1 because many hemorrhages will actually be bright by that time. So moving on. Your first stage of an hyperacute hemorrhage, it's still in active bleeding or the clot has not yet fully formed, so it might have the best circumscribed margins. However, blooming will already be apparent. First image to your left shows a hemorrhage in the left occipital lobe. You can see it's not very well defined on T1. On T2, there is a clot formation, which is slightly bright signal because there's still fluid in there. It's not yet clotted. And already in your susceptibility with the imaging, there's already blooming. As it degrades into an acute hemorrhage, the previously bright signal on T2 has now been replaced by low signal, and there's already better delineation of a clot. T1 is still not very well defined, but when it becomes a subacute hemorrhage, T1 shortening will now occur, so you can better delineate your hemorrhage. And on T2, it's still dark, but when the hemorrhage is already in the late subacute phase, it will be bright on both T1 and T2, which is a very helpful sign. As the hemorrhage ages or at its heals, it might leave encephalomalacia and will also leave dark signal. So it might be slit-like, it might be broad. However, it is like encephalomalacia, volume loss. There's no more mass effect. Comparing it to the previous hemorrhages where there might be compression because of the expanding clot. There are also hemorrhages that are not visible in T1 and T2. We call this microhemorrhages, which can be to a myriad of pathologies. In our setting, you might want to think of chronic hypertensive encephalopathy because this disease will attack your microvascular network in the brain with small microhemorrhages, small vessel ischemia, those things. However, this can also be seen in trauma, specifically diffuse axonal injury. Uh, do keep in mind that regardless of location of the hemorrhage might be inside the brain or it might be extraaxial. So their aging will remain the same. Another very common finding of your brain is what we call the white matter hyperintensities. This is actually a very broad term because a lot of things can cause this, but it's also seen in aging people. So by the time you're 60 above, we can see this in your brain because normally your white matter should be clean, I guess. However, in our setting, it can also be caused by small vessel disease, demyelination, inflammation, ischemia, those things. So it might not be very easy to differentiate. Um, one very notable cause is multiple sclerosis, but you might not be able to diagnose it in one MRI alone because you have to look for chronological or temporal changes, and sometimes you need to correlate with your other sequences. Here is an example of white matter hyperintensities which are periventricular in location. So meaning they fan out from the lateral ventricles. This is very characteristic of multiple sclerosis. Okay, moving on to masses. So masses are, of course, another thing that is useful to be evaluated in MRI because we can delineate their extent, their size, their signal characteristics, and whether their location is within or outside the brain. It's best used with gadolinium because a lot of masses will enhance, and sometimes you can't even see them at all unless you administer contrast. With our broad differentiation of masses is whether they're within the brain or extraaxial just overlying the brain. So we have specific signs to help you differentiate. Example of a very common mass, it's not really a mass, it's a cyst. Arachnoid cyst is one of the most common cysts in the brain. It's usually in the middle cranial fossa, overlying the temporal lobe. So here is a sign of it being an extraaxial lesion. You can see that the temporal lobe matter has been buckled or displaced. There's clear connection to the subarachnoid CSF spaces. So arachnoid cysts demonstrate fluid or CSF signal in all sequences and are benign. So here, there's complete suppression of the fluid of the cyst on flare, and there is no restricted diffusion on DWI. If a cyst, if an extraaxial cyst shows there's restricted diffusion on DWI, consider an epidermoid. Okay, so meningioma is one of the most common lesions. It's an extraaxial mass which arises from the dura mater. One of its characteristics is its avid enhancement, meaning it enhances very strongly. And of course, we have a dural tail. Oh, one moment. Nag-meeting ko. Sorry about that. So meningioma shows a broad dural attachment and buckles underlying parenchyma. Here's another example of a meningioma overlying the left frontal lobe. So you must never say that a meningioma is in the brain. It's not in the brain. It's extraaxial. So you cannot say in the lobe. It's rather overlying the brain. You can see here on the T2 sequence to your right a CSF cleft, meaning that the mass is surrounded by CSF. And of course, again, there's buckling. You can see magnetic susceptibility in this meningioma, showing it might present as high vascularity. It's a very vascular tumor that explains the IVID contrast enhancement. Then you can see here there's mass effect. So you can see that the structures deep to the meningioma are displaced to the right, even the septum pellucidum, meaning there's a midline shift. One of the more dangerous masses are astrocytomas. This is a very wide classification of tumors, and differentiating them is not very easy. However, they range from benign to malignant, and sadly, the most common is the malignant type. So we have these gliomas, which can either be circumscribed lesions or very poorly circumscribed ones with infiltrating appearance. So you might not really you cannot really demarcate normal tissue from brain normal tissue from the tumor anymore. Image to your left is a flare sequence with poorly defined mass evolving both thalami, and you can't really see the margins. It's high signal. It's diagnosed as a glioma. We used to call it glioblastoma multiforme. However, that's not a term we use anymore. We have some nomenclature which was changed in the World Health Organization 2021 CNS tumors. Image to your right is a T2 weighted image showing a well-defined mass in the left parietal lobe. It's interaxial, and you can see it's a bit well defined. So both astrocytoma. So another one here, there's a slightly demarcated mass in the right frontal lobe, and image to your right is a large cystic mass with a solid component, which is common in children, the pilocytic astrocytoma. Excuse me. So for my closing, I cannot I cannot explain everything about the brain in just a time span, because a lot of the things in the that go on the brain will take years of studying, because there will be differentiating and there will be times when you're not really sure what you see in the brain. Always ask your radiologist about this, and sometimes you really need to do repeat scans. Why? To check for the temporal evolution of the lesion. The brain is almost always symmetrical, meaning right and left hemispheres should look the same, aside from the midline structures. And always do the WI if you as the first sequence if you're looking for infarction. Regarding masses, remember, MRI is great for delineating them, but it might not be enough to know if what the mass is. So remember that ref, you have to refer this to your clinicians who might know, do a biopsy and things like that. It's problem solving, yes, but it's not the end all thing. So I hope this short lecture has been insightful, and maybe it might attract you to pursue MRI when you practice as a rad tech. So don't be honest, Soto. In life, nothing is certain. So I hope you keep that to your heart, and I thank you for listening to me. Goodbye. Hello, I'm done.
Thank you, Doc, for your exciting and engaging presentation. We are glad that VSMMC MRI Division definitely graced this day's webinar. Let's give them a round of virtual applause, please. Now we will proceed to an exciting segment, our Q&A session. We invite all participants to share their thoughts and engage in conversations with our esteemed speaker. You may now type it in the chat box, or you may use the raise hand emoji found in the reactions. Good morning, Doc. We have our first question po from Jan Yulin Katubig Lagrimas. Here's the question. Are there specific scenarios where MRI might not be the preferred modality, and why?
Oh, thank you for that question. Yes, MRI is clearly a good thing. However, it's not the best modality for everything. Why? MRI takes time to scan. MRI might take an hour or so, and in an emergency situation, for example, you suggest stroke or hemorrhage, and the patient might not cooperate because in MRI motion might happen, and if motion happens, the MRI scan is essentially useless because motion artifacts will really distort the image. So you might consider doing a CT scan first because it might detect a hemorrhage, a mass. Then when the patient is stable or more cooperative to do an MRI, that's when you do the MRI. And
Thank
as
you, Doc.
previously mentioned, sometimes you need CT scan to verify for calcifications, hemorrhage because they're also sensitive, and you can do that in 5 minutes or so. And I'm sure a patient with a hemorrhage might not be your most cooperative person.
Okay po. Thank you, Doc. So we have our second question po from Jan Yulin also. Considering the recent developments in AI-powered image analysis, how do you see the role of MRI technologies evolving in the future?
I cannot give a proper answer because we don't use AI or in our institution. However, in my point of view, AI is meant to supplement, not replace, because it still takes a licensed radiology technologist to actually perform these things. And we can't really depend on the AI to catch everything, diba? Because sometimes you need the verification of a rad tech and a radiologist to make sure this is really a lesion, because from what limited AI technologies I've used, it's not yet perfect, and of course, it's not a licensed professional.
Thank you, Doc. So we have another question po from Aljon Peter Morillo. Here's the question po. What is the common abnormality in the brain that is usually found on both T1 and T2 weighted images?
That's a very broad question, but if you're thinking about very common, it's definitely, if it's apparent on T1 and T2, then you can look at hemorrhage, because as I mentioned before, late hemorrhages present as a high signal on T1 and T2 when they're late subacute, so it's very apparent. And masses. Masses have a wide range of imaging signals on T1 and T2, but their most common feature is when they're big enough, they compress other structures. And another thing is developmental anomalies. So you might see congenital things that are very apparent on T1 and T2. For example, congenital hydrocephalus, or you might see um, abnormal formation of the hemispheres, like in schizencephaly, in uh, cortical dysplasia, and other causes of hydrocephalus. So these are very apparent, especially in T1, since you're looking for symmetry and anatomy. You might see abnormalities of anatomic differentiation, like there might be heterotrophic gray matter, there might be absent or fusion of the ventricles. I just look at in holoprosencephaly. I didn't really discuss those because it's a very wide spectrum and it's not seen in the acute setting.
Okay, thank you, Doc. We have another question po from Sir Jimwell Fred Kapukyan. Regarding with the sequence, usually, it's the radiologist's choice ba to use or naka-protocol na?
From what I recall, there's a standard protocol that is set in the hospital manual, and of course, it's the sequences, the basic sequences, DWI, ADC, T1, T2, flare are agreed upon with in literature. However, it really depends on your institution, because it's better if you sit down between rad techs and radiologists what they want per organ. There will be specific sequences, and from there, it's the radiologist's initiative to be creative or to think outside the box and what to add to know if this is the right sequence for what he's looking for. For example, you get a brain MRI, but the radiologist thinks that this requires contrast, or sometimes you need to do cysternography or angiography, and they're gonna add that to evaluate the circle of Willis. It's not in the standard amount of protocol, but it's a supplementary protocol. It really depends on the patient. There is no one size fits all. You go from the basic list and you expand from there.
How about naman po from other schools from the HIC, Lormac? Are there any questions po? If there's no more questions to our speaker, then we will proceed to the awarding of certificate as a token of gratitude for our first guest speaker. University of Eastern Philippines, University Town, Northern Samar, Bachelor of Science in Radiologic Technology. This certificate of appreciation is awarded to Mark Seymour Mabalatan, MD, FPCR, FCT MRI SP, for sharing his expertise in common MRI findings during the webinar entitled Looking Good M-R-rIght via Zoom and Facebook Live, given this 13th day of April 2024. Signed, Jasmine De La Cruz, BSRT-3A President. Signed, Christine Camille Havinas, MSRT, BSRT Program Chair. Signed, Sara B. Di Lorino, PhD, College Dean, and Cherry I. Ultra, PhD, University President. To show our appreciation in chat, a virtual applause, everyone. And now, may I request all of you to switch on your cameras for a group photo opportunity.
Okay, everyone. So please turn on your camera so we can have a photo op. So, okay, ready? 1, 2, 3, smile. Okay. So the next group, next slide. Okay, so for students from Lorma College and Holy Infant College, please turn on your cameras. Ready? 1, 2, 3, smile. Okay, so last. 1, 2, 3, smile.
Ano na comes? Kaya magkaboy ng smile.
We are also informing everyone to please fill out the evaluation through Google form. It will serve as your attendance and for the issuance of electronic certificate of participation. We'll be sending those e-certificate to respective emails.
Doc, thank you so much for the
Thank you po, Doc.
No problem.
All right, so that concludes our first lecture with Dr. Mark Seymour Mabalatan. And let's have first our warm-up activity prepared by Dynamic BSRT38 officer, which will be facilitated by Ms. Christine Erica Go.
So hello everyone. Before we proceed with our next speaker, we will have a short icebreaker. Before we begin, let me quickly run through the rules of the game. Here, we will see if you really paid attention to our webinar. You will be presented with a crossword puzzle on the screen, and your task is to fill in the blanks with the correct words. You will make an educated guess, and when you know the answer, kindly inform everyone by commenting your answer in the chat box. So, this round will test your speed, your accuracy, and quick thinking. So, kung sino po ang mauna, siya po ang mananalo ng washing machine. Sure.
mabulig ako. Washing machine.
So, the first question.
Yasmin, nagdalaga na po.
I-invite ibang schools ha if they want to.
Sigara.
Nakikita, Char. Nakita.
So, our first question.
Uy, nakikiaw ka lang.
A medical imaging procedure that uses a magnetic field and radio waves to take the pictures of your body's interior.
Damo nagulatan washing machine.
Ariel got the correct answer. First one to get the correct answer, congratulations po.
Mariel ba?
M-R-rIght.
Kuan man, Mariel Sam. Oh, Mariel.
Next question. The process of making a visual representation of something by scanning it with a detector or electromagnetic beam.
Naunang taga Heart Center.
The first one to get the correct answer is Miss Nerza from BSRD 4. Congratulations. Next. So next is we have the neural tissue, especially of the brain and spinal cord, that contains nerve cell bodies as well as nerve fibers and has a brownish gray color. Forgot the correct answer? Oh, from Lorma College. Balazon, Norma B is RT3, Balazon. Congratulations, nanalo ka ng rice cooker. Emmy!
Naman budget yan ah.
Thank you, thank you. Next. Number 4. A branch of medicine dealing with the development, care, and diseases of infants, children, and adolescents.
Ano ng tagaw si
Come on,
Ray?
guys. Oh, you, Miss Perit Generos from UEPB's RT4. Congratulations.
Rice cooker?
Pediatric. Nanalo ka ng rice cooker ulit. Emmy!
Tag 50 ang rice cooker.
Next. Last but not the least. Directed toward or situated on or in or near the head.
Ano taga heart center?
Yun, from BSRT4, Achazo.
Anong premyo? Cellphone?
Congratulations po. The answer is cephalic. Congratulations guys. I-claim na po ang inyong prize sa UEP College of Nursing worth 50,000 pesos.
Uy. Uy.
Just message our BSRTA President, Jasmine De La Cruz. Thank you, everyone.
So this is the end of our short icebreaker. We hope you have enjoyed and ready for our next speaker. A person's smile, eyes, and confidence are some of the true qualities that make them attractive. Enjoy this unique teaser video featuring our Mr. and Miss RadTech 2024 that our BSRT class officers have prepared, which explores what is the most attractive part of your body.
Hi, I'm Lorraine J. Cisneros, 18 years old. You're Miss RadTech 2023.
Hi, I'm Matthew Zoilo Pohante, a first-year RadTech student and the current Mr. RadTech 2023.
I was absolutely shocked as they announced my win, as I hadn't expected it at all. I just enjoyed the pageant and gave my very, very best and at any category of the pageant. I was so overwhelmed by the support of my classmates and friends as they are shouting my name filled me with gratitude and happiness. It is the moment where I feel seen, appreciated of the way I am. It is the moment that I always cherish.
So the moment I was crowned as Mr. RadTech, it was a fun and memorable experience for me. Even though it's not my first time joining a pageant, I previously joined pageants back when I was in high school, but this previous pageant or the Mr. RadTech 2023 was a unique experience for me. It boosted my confidence since I am a first year RadTech student, so I am still at this part that I'm adjusting in the college life. So it really helps me a lot to boost my self-confidence and be myself.
I've gotten some heartwarming compliments which helped me gain my confidence. Kasi I used to be self-conscious woman about my physical appearance and potentials. And I've eventually come to the realization to what more I can be and what more I can prove. It is indeed an honor and great privilege to be the Miss First Radtech and UEP.
So the changes that I have experienced since I was crowned as Mr. Radtech is that I was slightly acknowledged and recognized by the people around me, not only in our department but also those students in other colleges and department. It also boosts my self-confidence and self-esteem. But I don't take it for granted for winning the title. I still remain humble and just as I am.
I think it is my hair because it gives me so much confidence and femininity. I used to hate it before because it looked messy and frizzy, but now I'm starting to embrace my curls because it gives me so much confidence and femininity. That's why I found it very, very attractive.
So the most attractive aspect about me, I think, is my skin tone or my pagiging moreno. I think that's the most attractive about me since I receive a lot of compliments about that. And I can prove that since a lot of gays or girls really love the way my skin tone is. And when I joined pageants, the most appealing about me is my skin tone and my body figure, since I receive compliments that they say that I look like a Bombay daw, but I'm a pure Filipino and I'm really proud about that.
At this point, we will witness another inciting teaser video featuring our BSRT4 students. Enjoy, everyone.
Asking the SRT for students. What is the most attractive part of your body?
Isabel, what do you think is the most attractive part of your body?
The most attractive part of the body is my neck. Turtleneck.
Hi, Teresa, what do you think is the most attractive part of your body?
I think it's my eyes.
Wow, no.
Kasi mas makikita mo kapag stress na, pag napupuhay.
Okay, Cheyenne, what do you think is the most attractive part of your body?
I think my nose, because I can smell
Stress na lang.
So Mary, what do you think is the most attractive part of your body?
I think it's my cheeks.
They are blushing.
So Giselle, what do you think is the most attractive part of your body?
So the most attractive part of my body is my lips. Wanna try?
Nicole, what is the most attractive part of your body?
I think my boobs. But don't touch.
Rico, what do you think is the most attractive part of your body?
My eyes.
As this At this juncture, may we call on Professor Dermalindi Malubago to introduce our second guest.
Salamat, Mr. Oreo. I am audible po.
Mr. Oreo, to our active
Yes,
program
Derms. Yes,
chair.
Derms.
I am audible po.
Yes, Derms.
Okay, so to our UAP President, Dr. Cherry I. Ultra, to our College Dean, Dr. Sara B. Dolirino, to our active program chair, Prof. Christine Camille Sasaya, to our energetic college research coordinator, Prof. Ronchelis Tonilo, to our senior faculty members, Prof. Rigel Capuno, Prof. Remy Baldiata, Prof. Jimuel Kapukian, and to our BSRT students, guests, viewers, a blessed morning to all. I am pleased and proud to introduce to you our next guest speaker. I'm so excited and happy and aram ko what excited come to learn from the Igkasay Nortihano, a skilled radiologic technologist regarding pediatric M-R-rIght procedures. So let's get to know our next guest speaker. He has earned his bachelor degree in radiologic technology at Cebu Doctors University, Cebu City here in the Philippines. He is a licensed radiologic technology here in the Philippines and a licensed M-R-rIght technology in American Registry Technologies issued by American College of Radiology, USA. A former UEPB's art instructor, worked as a rad tech at Katarman Doctor Hospital here in Northern Samar, worked as a CT and MRI technologist at Dr. Sulaiman Al Habib Hospital and Mediclinic Hospital, Dubai, UAE. Now, he's currently employed as MRI technologist at Alvera Health Hospital and Sanford Hospital, USA. Mabruk. On your screen, let us give our warmest applause to our next guest speaker, no other than Sir Donald Ian Binoboblet, RRT. Keep halik, Sir Donald.
Hello? Yeah.
Hi, sir.
Yes. Can you hear me,
Hello,
guys?
sir.
Apo, sir.
Okay.
Hi, sir. Good morning.
Yes.
Good morning.
Good evening.
Yeah, good evening dyan sa iyo, sir.
Good evening. Okay.
Pag-blooming naman.
Yep. Can you see me? I
Yes,
don't think
po.
my video
Yes,
is
sir.
open. Oh, naimod kam sa akon. Wait lang. Okay. There you go. Well, it's my first time of like using this Zoom for like meeting. So should I like share my screen or whatever?
Yes, sir, you can po.
Share the screen. Okay. All right. All right. So, by the way, I'm so excited and so humbled to get invited to, discuss about MRI since I've been working for almost like 9 years as an MRI tech. When I started moving to abroad. Wait, why I can't see you? Okay. So thank you very much, Sir Ranjil, Ma'am Camille, and to especially Sir Ranjil and to BSRT3 for inviting me to have this lecture. Can you hear me?
Yes, bro. Yes, sir.
Okay. All right. So we'll be discussing about pediatric MRI. So I hope like some of our students have desired to work in an MRI or work as an MRI technologist. There's a lot of like vacancy or like scarcity of MRI technologists worldwide, specifically in Middle East and UK and even here in United States. So to start with, so I got, all right, pediatric MRI. All right, I got a content. So I won't be discussing pediatric MRI alone. I also will discuss history, a little bit of physics, basic safety, basic sequences and imaging acquisitions, and so on, with our sample MRI pediatric protocol in our facility. So in 1976, MRI looks like this. So it's like, I don't know, it looks like an abstract, right? It looks like an abstract, picture without, I would say it's hard to use this image for a diagnostic purpose. But at present, this is our MRI image. So this is an image of our 7 Tesla machine. So for MRI basic components of magnetic resonance, so we got like the hydrogen proton, large static homogeneous magnetic field, and radio frequency signal. I hope I am not like speaking like so fast. Is that okay? Hello?
Yes, sir.
Yeah, okay.
Dinirinig ka po.
Okay, thank you. So why hydrogen? So in MRI, we're taking advantage of the hydrogen protons in our body. So why hydrogen? So hydrogen is abundant because it has, our body is like made up of 70% of water, and each water, there's like 2 hydrogen protons. And it has the strongest magnetic moment in any substance. So a hydrogen acts like a magnet that has a dipole magnet. So each magnet has its magnetic spin. So back when the timeline for MR imaging, it started in 1924. So just like a theory of the magnetic momentum of spins, then Rabbi started it from Pauli, Rabbi Purcell, and then it was like in 1980 that started to rename it MRI. Before we used to call them like nuclear magnetic resonance, or it's like a phenomenon for magnetic moment. All right. So next. So there are like a couple of Nobel Prize for physics for this reason. So Felix Bloch, Edmund Purcell, and yeah, they made a history by. Okay, so magnetic resonance technique. We have specific techniques like nuclear spin phenomenon, nuclear magnetic resonance, the MRI, echoplanar, the functional, and the spectroscopy. So as early as Röntgen's research was open doors about like physics and imaging body. So in MRI, we're taking advantage of this proton spin. Sorry about that. So, okay. All right. So a proton has like specific precisional spin. That's what taking advantage of the imaging. So this BO is the main magnetic field. So if you put a proton or a patient inside the MRI, it will align to this BO, or the main magnetic field. So how does an MRI work? So an MRI works with the magnetic field aligns with the nuclei. So this is the magnetic field, or this is the BO. So RF pulses tips the nuclei, and then it like influences for the precision. So each nuclei preserves giving of RF signal. So each proton spin, and this is not like 2 or 3, this is like billions of protons that are like spinning and then giving off signal. So in giving off signal, so in T2 relaxation, when we give off RF energy, so this proton started relaxing. That's why we call it T2 relaxation. And we will get there with the T2 and T1 weighted images. So if it's like realigned from high energy, which is like anti-parallel to the main magnetic field, we will achieve like a T1 relaxation. So why resonance? So it's a physical principle that allows energy transferred efficiently from one object to another, causing a receiving to vibrate and same frequency as the sender. So we would like, it's like a signal or like a tower that's giving off same frequency as what we're receiving on the transistor radio. So if it's like 99.9 megahertz, so if it only accepts signal from the station in the same like frequency. So that's how the M-R-I works. So M-R-I is like changing the frequency by giving off RF to this to a certain proton so that the machine can receive that signal. So in that detected signal is a theory of the Larmor equation. So Larmor equation is like a precisional frequency is equal to gyrometric ratio and magnetic field. So magnetic field, we would define it as like the main magnetic field, which is like on Tesla. So for example, we have a 1.5 Tesla machine. So we put 1.5 Tesla plus the gyrometric ratio. Gyrometric ratio differs from each, like, so it's like the speed at 1.5 Tesla will achieve like a gyrometric ratio of 63.86. So the higher the Tesla, the more like gyrometric ratio. So the faster the precisional spin would be for the individual hydrogen protons. So if you put the patient in a magnetic field, the tendency of those protons without using the gradients will align to the magnetic field. So it is like it's either will align or will anti-parallel, which is in a high energy state, and then they will cancel each other. So the main components of the M-R-I machine. So the static magnetic field coils, gradient field coils, magnetic shim coils, radio frequency. So it's more like a lot of coils and data transfer and storage system. So this is the main magnet, the purple one, and then gradient coil. So without the gradient coil, it's like an untuned guitar. So gradient coils is like a tuning, so it can achieve or you can hear the sound desired for diagnostic purpose. And these RF coils receive the signal from giving off for this main magnetic field. So each precisional frequency. So at the 4 Tesla magnet, this is a very old magnet. So this is the equipment construction. We get the RF, which is the coil receiving, and then the gradient. So the purpose of the gradients are like to locate the selection and which part of the patient should be scanned. So that we were just altering the precisional frequency of each proton to achieve signal intensity. So this is the main magnet from before. Yep, and this is the gradient coil and the RF coil. There's a lot of like types of coils in MRI, which is like used for the imaging. So, well, pediatric MRI, before imaging is just a 50% of what we're doing in an MRI facility. We usually, the 50% of that should be focus on safety. So yeah, like this graphic, we usually like takes care or takes time for like screening patients and giving them education and, you know, just to be safe, because MRI is a very strong magnet. In fact, it's like 60,000 more, 60,000 more stronger than the Earth's magnetic field. And of course, in our facility or in anywhere we don't want this to happen, this is like a very expensive lawsuits. So yeah. So guys, be careful if you're working in an MRI facility, just be mindful of like entering the MRI. You should be at least screened for safety. Yep, this happens. And yep, this is a patient that got stuck because of like a flying oxygen tank. Can cause some missile effects. Yeah, we don't want that. Okay. All right, the safety challenges. So the procedure volumes and continue to increase annually. So the more the patient, sometimes, you know, screening is, we want to do a lot of patients. So sometimes you forget to like screen the patients specifically with, you know, because MRI takes time. It took like an hour or two for scanning. So this MRI systems are more complex. So we got like very high field strength machines, which are really, I mean, you have to be careful. So we got like stronger and faster gradients, which is, there is advantages, but there is also disadvantages by using higher field strength or like stronger magnetic field. It can cause, if the implant or a specific metal is not like compatible, it can cause burn. Even if you guys have like Lululemon, something like a spandex or a yoga pants, there is like metal fibers in there. We got some patients got burned because of that. So there is like a global staff shortages. So there's like, in my facility, I'm the only one who is like doing all the scans, positioning, screening at the same time. So yeah, it can cause, can cause some error, or like no one is like watching your back or like helping you screen some patients, which is prone to like have safety issues. Okay, so education doesn't change as much. False feeling that the MRI is safe because it's not like X-ray with like ionizing. fallacious PR, and lack of understanding for higher management and importance. So MRI usually in the radiology facility is one of the workhorses because their procedure is pretty expensive than other modalities, if not the most expensive. Here in the United States, I got some procedures that cost like around $10,000, so around 550,000 each procedure. So I'm doing like around 24 of them every day. So since MRI is a new technology, there is lack of facility accreditation, which is like since even ACR cannot is still researching on what's the safe and unsafe. We're still, and it's not like X-ray that is already like established on safety. MRI is still developing technology, so that's a bummer for us. Okay, so in MRI the bioeffects, we measure safety by this tool, which is the specific absorption rate established by the FDA. So as of now, we are following the standard of like all MRI technologies must be knowledgeable, and then there's like specific implants that require a specific absorption rate. So you cannot, if you increase with that standard absorption rate, then burns may occur, or like you can damage the implants. So I'm sorry, I was talking about all the implants because most of the patients, or probably half of them, has like implants, whether it's a foreign body, a bullet, or like any pacemaker, or like aneurysm coils, brain coils. That's like always a hindrance for my scanning. So there is like possible biologic effects. We call it magnetophosphenes, flashes of light, and subjected. Well, this is not pretty common, but there are some patients like experiencing this. Most common is the skin burn when exposed to higher RF. So if the ECG electrodes are not compatible, please don't put it inside the machine, because it can cause this type of burns. Yep. And it started like a single dot of burn until it spreads like an inch or two. And yeah, we don't want that lawsuit again. So how to prevent the accidents burn in MRI? So as per FDA, yeah, this is the allowable range for the specific absorption rate. The SAR must not no more than 3.2, or like maximum peak should be 8. But in our facility, we just focus on 2 per kilogram because that's the safest for all the implants. And then proper screening for metals and implants, and proper education for staff and all the technologists. All right, we got a sample MRI questions. So we're asking if there is like a pacemaker, any head injuries, or like surgery requiring aneurysm clips. If we have, although the latest type of aneurysm clips from 2002 to the latest is acceptable until 3 Tesla. But we should always like ask the doctor or the magnetic safety officer, MRI safety officer, if that's really compatible. And some ask for any surgeries, metal pins, any contrast agents, although it seems so rare, but there were some patients that has like an MRI allergies, MRI contrast allergies, and metal fragments for any patients that doing some metal works, welding, or like working in construction. So most common is like the hearing aids. This could damage the hearing aid implant. So do you have any tattoos? So any tattoos that are like recent or like probably less than a year. And some of them are like metallic properties, which can cause burn. And any transdermal patch or medicine patch. And, claustrophobia, it's a common thing. It happens with 80% of the patient. Proper education is the key for doing a scan. So history of food allergies or drug allergies that we might give through the process. And then we have to check the renal disease, if there is, because of the contrast. Contraindication, if it's like there's like undergarments, or for patients that have IUDs, or pregnancy. Although pregnancy is not like proven to like damage the baby, or like there is like biological damage to the fetus or the baby while doing the MRI, we still don't recommend doing MRI on the first trimester unless it's really needed. And then breastfeeding. So some patients that are breastfeeding are not allowed to give contrast because it the contrast is absorbed by the baby's mother's milk. So we don't want the contrast to be transferred to the baby. So why doctors prefer MRI for pediatrics? So there's like a couple of reasons for advantages for an MRI. So just, unlike the X-ray, MRI doesn't use any radiation. It has cross-sectional images, just like the CT. You can image in any plane. So it's not the same as the CT scan, when you can just acquire an initial transverse or axial images. So MRI, you can get a coronal image right away without reconstruction. So most MRI, or like all of them, are digital images. It's not like common to have like the conventional MRI. So MRI has exquisite tissue differentiation compared to other modalities. So in MRI, you can do an MRA or angiograms, whether it's like a brain angiogram, extremity angiogram, without contrast. So this is the image of, this is T1 as per, I think Dr. Mark has better images than I have, but this is like a comparison for a plain scan for brain. And this is the T1. So as per him, T1 follows the anatomy because white matter appears white and gray matters in gray. So the basic acquisition images for MRI, we got T1. So we call it T1 weighted because the repetition time is less than, it's like ranging from 300 to 600. But in our facility, if it's like less than 1000 millisecond, it will be considered T1. So T1 is like low TR and low echo time. Echo time of just 10 to 15 compared to the T2, which has like 120. So there's like uses of like a T1. It's used for abdominal imaging with respiratory gated scans, and it's also used for chest imaging. So basically, like most of the musculoskeletal, like even for like spine, orbits, and extremity. And this is T1 is used for contrast. So after injecting contrast, you should run a um, T1 sequence, because that's the only sequence that differentiates contrast from non-contrast. So yeah. So again, this is the T1 image. So as you see, the CSF in T1, if you can see it in the lateral ventricles, T1 is like the CSF is dark. So it's T1 is not sensitive to fluids. They're sensitive to the white matter. They're more like sensitive to the brain white matter. You can see the basal ganglia properly. Okay, we got a couple of like images for T1 sequences. So spinal cord appears dark, or like somehow, yeah, you can differentiate. So CSF is more darker because T1 is not sensitive to like the fluids in the body. So we can also use T1 to differentiate or like look for any bone lesions, especially for like bone edemas. So this is a normal scan, so I cannot like, I'll show you one image right here. Okay, so we got a shoulder. So we can see if T1 is also used if we want to see like a bleeding. Sometimes there's like a joint bleeding, or any bleedings will appear white. And then an image to your right side, we can see this is a post-contrast image, post-gadolinium image. So the bright sides are the contrast enhancement. So it appears like it is like hyper intense on the lesions, because contrast in the gadolinium is a paramagnetic agent. That means there is like a metallic properties on it that acts as like enhances the lesion or the blood vessels. So we got the T2 weighted, from fluid filled images of spaces in the body. We use it for MRCP. We'll take advantage of the synovial fluid, urinary bladder. So if you want to see like hydrocephalus, or like if you want to see the brain ventricles or the spinal canal. So it's very useful for abdominal imaging. Pelvic, chest imaging can be useful in brachial and lumbar plexus. So basically, if you're interested with like fluid or any edema lesions, cystic lesions specifically, you can take advantage of T2 weighted imaging. So these are samples. So as comparing to a T1 weighted imaging, so you can see that the ventricles appear white or hyper intense. So T1 has like hypo intense, but T2 is sensitive to fluids. And then it takes advantage. So this patient has like a facial cyst. And then you can even see the maxillary sinus, that there are some fluids in there. So T2 sequence, again, this urinary bladder, it appears hyper intense, the CSF from the spinal canal. And this specific patient has like anal fistula, and yeah, you can see like certain edemas. It appears like hyper intense on the specific parts, like this like presacral region. That means there is like fluid accumulation on that side, probably like an ascites. So you can see like narrowing if patient or like a neurologist is suspecting for like narrowing of the spinal canal. So T2 is your best friend for like imaging for spinal narrowing of the like cervical or some of these CSF. So just to compare, T1, as I've said, CSF is black. This one is white. But then we got a third sequence. By the way, there's a lot, tons and tons of sequence available, and tons of sequence each vendor offers. We're just focusing on this 3 basic MRI sequences. So CSF is dark gray. So if you can compare it with this side, so we take advantage of like flare by imaging lesions, like brain lesions. Sometimes T1 would hide it, T2, sometimes, you can't see it better, but flare is your best friend because it's like T2, but then, so it appears like same contrast as T2, but the inversion recovery, so there's like this CSF fluid was like inverted. So that's why it appears dark. It's not T1, but it's like T2 flare. We just call it flare, but it's really T2, but inverted fluid or inversion recovery. So yeah, white matter is gray, fat is white. Most of them, like fat is white. Okay, so pediatric challenges for MRI imaging. So risk for MRI, there's like problems for undetected metal, implants or foreign bodies. So, most MRI patients, you cannot just ask them what's wrong, or you cannot just, because they're kids, and sometimes some of them has like um, mentally challenged patients, with like delayed milestone. So younger patients have short attention span, just most common to kids, especially under 6 years old. And then another challenge is like reactions to sedative or anesthesia, headaches, shivering. Well, that would be because most of our pediatric patients are like done with anesthesia, some allergic reaction to contrast, or like hives or itching. In rare cases, kidney damage, although it's pretty uncommon for like kids to have kidney diseases because they're so young. But sometimes, just to be sure, like in our pediatric policy, we have to do the lab works like creatinine, BUN, and the GFR. And then in a very rare case, I don't know if you have heard about this, like nephrogenic systemic fibrosis. So it's like if we're going to discuss this. I got like a couple of slides to explain those. So for pediatric challenges, number one is patient compliance. So we know that kids has like challenge on explaining the procedure. Most of them like don't understand yet, or most of them are like really challenging to be with. Some of them doesn't like something, some of them like anxious and hate going to hospitals. So I try to be like use the buddy system, or like try to be friends with them, try to like at least explain in a friendly way on how the scan is going. So again, anesthesia in some like cases. So, yep. So So anesthesia carry its own risk, not only for the MRI, but most of the kids has like lower doses than an adult anesthesia. Yep. So this is our MRI suite. This is our MRI compatible anesthesia machine. So we did some graphics for our MRI just to be a little bit friendly. But yeah, if it's like under 3 years old or like under 6 years old, I mean, most of the time, but not like 100%, most of them, but probably like 80% of them will go by anesthesia. So age appropriate for technology, um, doing MRI for kids is not like, so we got in a day, we'd probably do one MRI for pediatrics. So it's not really that common. And most of the coils are like designed for adult size. So what it means is like for their small bodies, we should also use should be a smaller type of coil for higher image quality, but some facilities doesn't have that. Oh yeah. Next is the limited field of view. So as I've said, like smaller children requires a limited FOVs. So if you want an accurate diagnosis, sometimes it's challenging to use a bigger coil for a smaller patient. That means your spatial resolution will suffer. Sometimes like using super big coils will also like can be a little bit, sometimes it can cause like body to warm because bigger coils are like active, so it should be specific to which part of the body is like being scanned. And then yep, I got like an FOV, a bigger FOV plus a smaller FOV. This is for adult brain. I haven't done it for a pediatrics, but I guess we will suffer like image quality will suffer. If you can see here, you can see it better. We should achieve like, this is for like a CSF flow study. And then another challenge is the noise sensitivity. So yeah, MRI is really noisy. I don't know. Most of you was rotated in MRI, but the higher the Tesla is, the higher the scan noise. So there's like a couple of like techniques for safe, as per our standards here. You should not put a patient without an earplugs or like headphones. So most of them, we give like a couple of entertainment if we can explain. So anesthesia will be our last option. Most of them is like our MRI machine. There's like a monitor inside that's connected to their favorite shows like Disney Channel or like Netflix. So they can choose whatever like entertainment that they want just for a comfortable scan. Yeah, and then we're giving them some MRI compatible headphones. So at least reduce the noise by 70%. So as you know, kids, there's a challenge of motion artifacts. Most of them, you can't just tell them to, stay still or like don't move for like 30 minutes. It's going to be challenging, not only for the patient, but to all of radiology department to like ask a pediatric patient to not to move. So there's like a no motion scan. So nodding no, nodding yes. So yep, we did this scan for this patient, and then I was asking him if it's okay. Then he nodded no and yes. And, as a result, I got a couple of like M-R-rIght motion artifacts. Although in the newer technology, there is like M-R-rIght motion correction, like can fix the images by 10% motion. So, but yeah, motion is our enemy when imaging M-R-rIght. Our radiologist would not be happy with that. So anatomical variations. So children's anatomy differs from adults. So it's also a challenge for planning. Some of them are undeveloped, like knees or like their joints. So whenever we're planning for like like the image shown. So for this knee MRI, if official plate or the growth plates are not like fully formed yet. So yeah, it imposes a challenge for planning. Then communication barriers, some of them, especially for mentally challenged kids, effective communication sometimes doesn't work. So sometimes I'm asking the parents or like if they were like screened to be with them during the scan. Or sometimes there was one time where I asked a mother to lay down beside her kid while scanning, and it turns out successful. So yeah, sometimes we just need to be diplomatic and ask the patient whatever like makes them like comfortable during the scan. So another is parental anxiety. This is pretty common. Most of our patients are like, parents are like so anxious, they were crying, and there is like unnecessary fear. So you have to be empathetic for, try to be friendly with them and trying to explain the procedure properly. So they'll be clear and not like clear explanation of the procedure. Again, there's like equipment limitation. So most of the hospitals, because MRI is so expensive, most of them doesn't have the complete array of imaging coils. Some of them has like using the same coil for everything. Like in a previous facility where I used to work, we just got like a brain coil and we uses it for hand and foot. Sometimes a knee coil, I did scan a knee coil for pediatrics abdomen, which is not like supposed to be because of safety concerns, but yeah, sometimes we don't have a choice but to do whatever that we have, like use whatever that we have. So we got like specific coils for pediatrics, smaller, and it's even nicer and light and comfortable. So aside from those challenges, we got the gadolinium base. So most of our pediatric scan needs contrast because we already did anesthesia. So we want to take advantage of that. We don't want to repeat the procedure again. So gadolinium base or GBCA are like intravenous drugs to enhance the quality. So if you're ruling out like a lesion, a gadolinium contrast would help. So it has like paramagnetic agent. So it's T1 relaxation. That means it shortens the T1 relaxation. That means it appears bright through the image. Yeah, hyper intense on T1. So gadolinium is not safe. So in general, it's not safe. So by use of chelate, or someone, I might pronounce it like chelate. So chelate stems from Greek word chile. So it means pincer or crab claws. So it is used to, since the gadolinium is toxic to the body, so chelating agents is like, it acts like a claw, like surrounding, it's like a molecule that surrounds the gadolinium to overcome the toxicity. So this is the gadolinium molecule, or the gadolinium compound. So there is like two types of chelating agent. There's like linear, which appears like a zigzag. Gadolinium is enclosed in here, but in a linear pattern. So in hospitals or like government regulations, especially in Middle East and the United Kingdom or like European, they don't suggest like a linear gadolinium chelates. They usually use the macrocyclic. This is linear gadolinium chelates are already banned in like Europe and Middle East. So we usually use the microcyclic because of like it's safe, because you can see the compound gadolinium is enclosed, so there is no chance of like the extracellular exits for this gadolinium to create a NSF. So yep, if you can see or like have been assigned to a facility, you could probably like be using either one of this. These are brands and toxicity, or we usually in our facility we use a Dotarim or a Gadavist. So there's a more safe contrast than the others. So with and without contrast. So this is a without contrast. So you can see the lesions, but it's so subtle that it looks a little bit normal. But using contrast would enhance, it looks hyper intense. That means it's got absorbed by the tumor. So what happens after we die? Again, contrast imposed nephrotoxicity. So we always require a normal creatinine test or kidney function test, because we don't want injury or like a renal function. So we got a term for gadolinium retention. So before we used to do like, that's why it's banned in like Middle East and Europe, because of the gadolinium retention. So usually linear type gadolinium contrast doesn't like fully excreted in the body. They usually like stays in the body. So this is like the first scan on 2012. This is another 2002, I mean. So another scan on 2012. This is without contrast, but contrast deposits on the basal ganglia. So most of them like deposits in bone, which is not good. We want our contrast to be fully excreted to the body. And then this comes with the nephrosystemic fibrosis. So it's like a skin disease that's caused by, one of the cause is like like the gadolinium administration. So I got like, gadolinium contrast, like prolonged for some patients that are for example, like repeated scans. Some of them are like repeated in a yearly basis, like multiple sclerosis. So we need to follow up every year. We usually limit the dose for them, instead of giving the full 10 cc dose, sometimes the neurologist would request no contrast. If it's just a follow-up, if there's symptoms, then that's when he will request a GAD contrast. Again, okay. So this is a brain pediatric protocol. So pediatric protocol doesn't means only like pedias that already like 1 to 3 years old. Some of them are like in the mom's tummy. So we did this scan. We call it like the fetal imaging. So this patient had like an abnormal ultrasound. So we did a brain scan because the pediatric doctor is suspecting for like hydrocephalus. So as early as like pre-delivery, we can do an MRI. So yeah, even suspecting physical abuse, shaken baby syndrome, Sturge-Weber syndrome, acute severe headache, most of, developmental delays, which is common, encephalomyelitis if like congenital or it's like transferred from mother. Some of them has like neurofibromatosis, common cavernomas, just like an adult, most of the indications. Okay, so yeah, this is one of the image for the fetal imaging. And then, this patient has like a full CSF pocket on the lateral ventricle, which causing like a narrowing of the CSF flow. So contraindications. So any electric or magnetic mechanically activated implants. So cardiac pacemaker is not allowed. Any implants at all should not be allowed inside the MRI. Although there are some restrictions, there are some conditions like for specific field strength or like specific parameters that we can use it. So intracranial aneurysm clips, as of 2002 up to the present, it is compatible. What it has to be like monitored by the doctor if it's like aneurysm clips will be moving. So ferromagnetic, of course, not allowed. A metallic foreign body in the eye, shrapnel or bullet. So yeah. So basically no loose metals. So as like all of the procedures, so written consent should be done prior to this scan, and it should be done by the parents. Ask for patients to remove all metals, loose metals. Yeah, for chaperone for like claustrophobic patients, we are doing that. So contrast in injection risk must be explained. Offer earplugs or headphones. This is not like for comfort, but this is by law. You should offer like earplugs or headphones, and unless you can be sued. So explain the procedure, instruct. And this baby has like earplugs. So patient preparation in neonates, certain sedation, carbohydrate, but it should be done by our anesthesia team. Scan and wrap, for pediatric patient, it should be like a well-maintained temperature. So change nappies and available acoustic noise reduction sequences. Yep. Okay. So ECG electrodes must be removed prior to procedure. So we were like, this ECG electrodes that we're talking about is like the ECG electrodes that are not compatible with the scan. We have our compatible ones. And it's like a pulse oximeter. So patients are like monitored inside. we give them this is the MRI compatible ones. So, a scan planning. So like a CT scan, we should always start with a scanogram or a localizer. A typical localizer would be in 3 planes: sagittal, axial, and coronal. Then from this 3 reference, we can plan for the coronal. So yeah, forehead to the back side of the brain, posterior side, and then sagittal. We can so basically we can plan everything by using that 3 planes. So for axial transverse, the ACPC, or this is the corpus callosum, anterior and posterior. So we should also cover from the base of the skull down up to the vertex. Should not cut. Okay, so for some pediatric protocols, we should also include the hippocampus, or we call it the epilepsy protocol, for like, even if the scan is requested like a normal brain, but you ask the parent or you have seen the file of the patient that this patient has history of like epilepsy or seizures, you should always add additional scan for the hippocampus. Usually hippocampal cirrhosis or like any diseases involving the hippocampus means an epilepsy can be caused by it. So internal auditory canal, when we're scanning, we're looking for like acoustic neuromas. So we can see the acoustic nerve right here. If we want to see like trigeminal nerves, usually doctors will request for the IAC. So it's more like scanning the pontine area. Orbits, when some of patients has like optic chiasm or like optic neuritis, papillary edema. So we plan it like this, centering to the optic nerve for axial views, and it should be like as per departmental protocols, but most of the radiologists will trust the MRI tech. So if I scan, for example, there was like a brain scan and I already saw a optic neuritis, I don't have to ask him. I usually do some extra imaging, and then so at least you save time and effort for those patients not to come back. Or sometimes I'm doing an extra imaging and then they're going to request it afterwards, and they don't have to do the scan. I just have to upload the images, and then it saves time and money for the department. So after the MRI, table is undone. It's some patients like undergone anesthesia will be required to stay for like side effects or any monitoring. Caregiver should ask the doctor about sedation. Most of them were like under monitor for like half a day. In our facility is like half a day, just to be safe. So as per my conclusion, pediatric MRI is immensely important in assessing and managing children's health issues to its ability to provide detailed imaging. So for soft tissues, organs, imaging like CTs. So invasive techniques is essential, and also in conditions like brain tumors, developmental disorder, which is pretty common, a detailed anatomical and information. So preoperative planning and surgical intervention, usually they will rely on MRI for like navigation surgeries. So they're using the MRI thin slices for surgery planning on, so they will not, you know, they use it as guide for surgery. So overall, pediatric MRI is a fundamental tool for pediatric imaging and valuable insights in children's health and high accuracy and safety. So thank you. Yeah, if you have any questions, you can contact me with my Twitter or X or my LinkedIn or any questions, career, whatever. Yeah. Sorry, it was a long discussion. I hope I didn't bore you guys.
No problem, sir. We're still listening.
Because MRI physics is
Thank
really
you so much,
complicated.
sir.
Yeah. Yeah.
Thank you, sir, for your food for thoughts. Served all the way from the United States of America. Surely, this will be a great help to both student and professional radiologic technologists. Let's give him a round of virtual applause, please. Now we will proceed to an exciting segment, our Q&A session. We invite all participants to share their thoughts and engage in conversations with our esteemed speaker. You may now type it in the chat box, or you may use the raise hand emoji found in the reactions. So we have our first question po from Mariel Sambalasta.
Okay.
If the patient is stuck in the MRI, what is the first step that the MRI team make?
Stuck inside the MRI. So you probably mean like, that's so broad. We probably mean like a stuck with like an incompatible, like an oxygen tank inside. The first thing that we have to do is to call someone, but don't. We should plan it before going inside. So, our last like option is to quench the machine or just to turn it off, but it is the most expensive option. So we will ask like specific trained staffs. It depends the gravity of the situation. If it's like stuck, like, you know, a simple like gut stack inside, so there is like a our MRI table has like an emergency like knob. You can just squeeze it and patient will be ejected. Or if it's like there is like a, what do you call this, a foreign body or like a debris inside, then that would be so complicated. We need a lot of people, a lot of planning to do. But just to avoid it, I would really advise to like screen the patient, screen everyone, have them like screen everyone that enters the MRI suite, just to be safe, because that would be a super expensive mistake.
Thank you, sir. Another question po from Tina Francis Strogon. Can the parent or guardian request a break or adjustment during the procedure if the noise becomes overwhelming for the child?
Yeah, that's a good question. So there's like specific scans that takes 4 hours to finish. So a brain and a full spine for multiple sclerosis, it's like a 4-hour scan. So we sometimes give breaks to the patient. It's because of fatigue, you know. And yeah, we give breaks and then we try to do a localizer again, although we don't like it, but yeah, it's a matter of like comfort for patients. But yes, we can give them a break.
Thank you, sir. We have another question po from Genuine Lagrimas. What are the rewards of working as an MRI technologist, especially in pediatric imaging?
Well, this is my favorite question of all three. So, so I've been working in as an X-ray tech or X-ray and CT tech for a while before I moved to wait one second. Before I moved to as a MRI tech. So the advantage that I'm seeing is like MRI technologies is always like innovative. There's always like there's always room for improvement. So that's what made me switch to MRI. There's always a missing piece that technology is not offering as of this moment. So, like for example, motion correction, like MRI techniques, is not available 15 years ago, but right now it's fully available. There is also like white matter fiber tracking for surgeries. It was not available 8 years ago, and now it's fully working. And right now, with the advent of the AI, the artificial intelligence, most of the MRIs are equipped with artificial intelligence, which is makes way more easy for MRI technologists to scan. So basically, you just have to, you don't have to put much effort on like planning for the procedure because the machine will scan itself. It can even detect like in the computer aided like diagnosis. But yeah, I hope I answered your question.
We have another question po.
Sure.
If the pediatric patient expresses claustrophobia, what strategies are in place for managing their anxiety during the scan?
Okay. So that question is a little bit complicated. If we have to think about on a perspective of age, if they are like around less than 15 years old, probably 10 to 15, then we're going to ask some of the parents to stay with if they were like screened, or for under 10 years old and patient can't do it because they're anxious. So all we have to do is like call back the pediatric who requests the scan, and then tell them about the situation. And because he is, he's the only one who can request for an anesthesia. So most of the time, patients under 10 years old are like, or like patients under 6 years old are always under anesthesia because of the pediatric challenges. But most of like for me, anesthesia was my last option. So there's one situation where I scanned a 4 years old patient where I just explained the procedure and asked the mother to be inside the magnet with him, and he was okay with that. So yeah, scan turned out successful.
Thank you, sir.
Yep.
Thank you for answering all the questions.
Yeah.
And now that ends for our second guest speaker, and we will now proceed to the awarding of certificate.
Okay, just the last message to you. So anybody who is a student right now who wants or like has interest in doing or on a career in MRI technology, you should start learning as of now. So MRI physics is way complicated. So at least start learning. Don't be like me. It took me like couple of years to master or like to at least understand the MRI physics, which is really needed for the profession.
Thank you, sir.
All right. But I hope, yeah, sana maraming maging MRI tech kasi we need, and not to mention, it's in radiology, MRI techs are one of the well paid.
We are trying, sir, produce more rad tech that will more mag-incline sa MRI.
Yes.
Po.
Thank you, sir.
All right.
We'll now proceed to the awarding of certificate. University of Eastern Philippines, University Town, Northern Samar, Bachelor of Science in Radiologic Technology. This certificate of appreciation is awarded to Donald Ian Abablit, RRT, for sharing his expertise in pediatric MRI procedures during the webinar entitled Looking Good M-R-rIght via Zoom and Facebook Live, given this 13th day of April 2024. Signed, Jasmine De La Cruz, BSRT 3A President. Signed, Christine Camille Habina Sasaya, PSRT Program Chair. Signed, Sara B. De Lorino, PhD, College Dean. And signed, Cherry I. Ultra, University President. Once again, may I request all of you to switch on your cameras for a group photo opportunity.
Share.
Paano man mapagkuhan?
Ayun. Papapicture ako, Sir Donald, kay Tiyang ko ni US.
Please turn on your camera so we can have a photo op.
Ano daw kami?
Ready? 1, 2, 3. Next.
Next slide. Upat ini upat. May kanak comes.
1, 2, 3.
Normally, hindi rin naka-open ng camera. Sulog mo lang.
The next group. Please turn on your cameras. 1, 2, 3, smile. And then the last group. Okay, 1, 2, 3, smile.
Yan.
Okay, thank you.
Sir, thank you po.
Yeah.
Thank you, sir.
Effort talaga si Sir. Power.
Anytime, no problem.
Thank you so much, Sir Donald.
All right. Thank you so much.
Welcome back
All
to
right,
UEP
guys.
ko niyo, Sir.
Punta.
Yes, sir.
All right. Nice to see you guys. Kasi namimingaw
Now
galata.
let's take a break from our
Magwinarang.
engaging discussion and enjoy a captivating intermission number from the BSRT 3A students. Let's give them a round of virtual applause.
Kalasan kami niyan. Dapat na ito na.
Baliktad yung camera. Yung camera, masakit haligo ba? Yung camera. Jasmine, wait camera, masakit haligo. Ayun. Wow naman.
Thank you, BHIT, for that wonderful performance. And now we call on Teacher Rocket Archibald Asaguchi to deliver the success of our event performance. Virtual applause, please.
Dala talaga. Resource to may ba?
So, to our special speakers, faculties, interns, and fellow students, good morning. First topic of today's webinar is about the common M-R-rIght findings. Good morning. FPCR, FCS, and variants, common pathologic MRI findings in the brain, and also the masses. Sir Mabalatan gives a closing points, namely vast catalog of findings in the brain. Always coordinate with your radiologist for optimal sequences. Symmetry is key. Diffusion weighted imaging will save lives. And also, the second topic is about MRI pediatric procedure by the registered radiologic technologist, Sir Donald Ian Nababdit. During his discussion, he tackled about history, physics, basic safety, basic sequences, and image acquisition, pediatric challenge for MRI imaging, contrast consideration, and lastly, the sample MRI brain pediatric protocol. Overall, pediatric MRI is a fundamental tool in pediatric medicine, offering invaluable insights into children's health with high accuracy and safety. For today's webinar, it provided a deep dive into MRI, offering a valuable insights on common MRI findings and MRI pediatric procedures. Additionally, participants' engagement was encouraged through interactive fun games and Q&A sessions, fostering a collaborative learning environment by applying the insights shared today. Attendees are equipped to have gained more knowledge when it comes to MRI. Overall, this webinar successfully combined theoretical insights with real-world examples, leaving participants with actionable insights to implement in their respective fields. Once again, good morning and happy lunch, everybody. Thank you.
Thank you so much, Mr. Roque Acebochi. As we come to the culmination of this remarkable event, it is my great pleasure to introduce our BSRT President, Ms. Jasmine de la Cruz, for her closing remarks.
To our very active University President, Dr. Cherry I. Ultra, to our College Dean, Dr. Sara Di Lorino, to our Research Coordinator, Professor Rangel Estimilo, to our Program Chair, Professor Christine Camille Susaya, to our BSRT faculty members, Professor Rachel Capuno, Professor Remy Barrieta, Professor Dermalin Malubago, and Professor Jumel Capupian. To our guest speakers from the Vicente Soto Memorial Medical Center, Dr. Mark Seymour Mabalatan, and to our former faculty member in the UEPB's RT Department, Mr. Donald Ian Nabablit. To my fellow BSRT students in attendance, a pleasant morning to all of you. The purpose of this webinar is to give you valuable insights on magnetic resonance imaging. Dr. Mabalatan, our guest speaker for this webinar, talked about common MRI brain findings. Mr. Nabablit, our second speaker, covered important aspects of pediatric MRI procedures. As MRI continues to transform the area of diagnostic imaging, it is important to acknowledge its significant role. With the help of this webinar, I believe you will be able to completely appreciate the significance of different approaches in recognizing and diagnosing a range of illnesses that fall under the scope of MRI. We can improve patient care going forward and enhance the field of medicine by being aware of all of this. To our BSRT faculty members, especially Professor Del Estimilo and Professor Christine Camille Susaya, we thank you for allowing us to conduct a huge event like this. Thank you so much, sirs and ma'am. To our guest speakers, Dr. Mabalatan and Mr. Nabablit, thank you for sharing with us the necessary knowledge about magnetic resonance imaging, specifically the common MRI brain findings, pediatric MRI procedures. And to our fellow BSRT students, thank you for sparing us some of your time. To BSRT 3 officers, thank you so much. You did great in organizing this webinar. Thank you once again for joining this webinar. Let's continue to work together to make a difference in the lives of our patients, future radiologic technologists. Thank you.
Thank you, Jasmine de la Cruz, for your inspiring words. Your closing remarks have left us with much to reflect upon as we conclude this remarkable event. And now, for a further important announcement, may I call on Professor Rangel L. Isunilo, College of Nursing and Allied Health Sciences Research Coordinator. A round of applause, please.
Oh, may pa-applause pa. Thank you so much, Mr. John Paul Oreo. So, before I start with the announcements, I would like to extend our heartfelt gratitude to our speakers for today's webinar all about the wide range, the variety, and the special offerings of the magnetic resonance imaging. So thank you so much to Dr. Mark Seymour Mabalat from the Vicente Soto Memorial Medical Center. Through the help of my former student, and one of the radiologic technologists of Vicente Soto Memorial Medical Center, Mrs. Krisha Saira Dagami Mercado. Thank you so much, Sai, for helping me, convince and invite Dr. Mark Mabalatan, Dr. M, for today's webinar. And of course, to our very supportive former faculty member of the UEP RadTech department. I guess he's the former BSRT program chair, Sir Ian Donald Dabable. Thank you so much, sir, for being with us this morning. You have so very much insights that you shared to the students from UEP and to other schools. And also, we would like to thank our participants from other schools, from the Lorma colleges and from Holy Infant College. I guess they are still here. Yan, so 87 participants here in the Zoom and 60 plus viewers in the Facebook Live. So thank you so much. And of course, to our webinarians, to our eventologists for today's webinar session, to the BSRT 3A officers. So good job, guys, from the teasers to the backdraft layouting. You really worked hard for this, sleepless nights, and it really paid off. So thank you so much. So for our announcements, sige, pakishare na lang ang slide for our upcoming webinar that will be on May 4, 2024. So this is entitled very good. Thank you so much. So we have an upcoming webinar, again, that will be on May 4, 2024. That is entitled Kilig to the Bones. Yan, to the bones. Kasi tayong mga radtech, di ba? Sabi nga, we are to the bones kung magmahal. Sana all. And our next webinar title is aligned with this theme. Kasi nga, to the bones tayo kung magmahal. So ito, doon na natin to. So Kilig to the Bones, this is all about the orthopedic imaging. So please stand by for our further announcements in the UEP RadTech page kung anong mga topics at kung anong mga speakers, because we are still working out for this one. And the webinarians or the eventologists for this one, the assigned section, are the BSRT 3B officers through the effort of their class president, Miss Christine Perito. So for the level 4 students, your deadline, may mga level 4 students pa tayo dito from the UEP. Yan, mga interns. So for the deadline of your career development portfolio, that will be on Monday, April 15, 2024. So tomorrow you will be working your portfolio. So wala muna tayong klase because I'm expecting for your best output kasi this graded output siya on your CE2. All of your compilation on your attended webinars, both here in UEP and for outside, that's for your career development, that will be recorded and part of your grading system for your clinical education too. So I will expecting that tomorrow you will be working it out for the best effort and for your presentation, so in a whole. Okay, so our competency upgrading will end probably next Saturday, that is April 20. So we will have our final competency upgrading exams, so that will focus more on mga radiological sciences. So keep posted with our Google Classroom. So again, for the BSRT4, deadline of your career development portfolio on Monday, and the finale of our competency upgrading for our UEP in-house, that will be on April 20. So please prepare for the different radiological sciences subject. Okay, so for the BSRT3, I know you are having a hell lot of the effort is talagang binubuhos na lahat ng mga taga BSRT3. So we have upcoming events. We have a lot of activities in line. So the first among which, of course, katatapos lang itong webinar, the Looking Good, M-R-rIght. So thank you so much again sa mga nag-facilitate nito through the effort of the BSRT3A class president, Miss Jasmine de la Cruz. So talagang bonggang-bongga, no, from teaser to mga speakers. So I hope everyone enjoyed at talagang we are expecting that may nakuha kayo dito na talagang magagamit nyo not only because for the sake of your academic related subjects but magagamit nyo as future radiologic technologists. So aside from that, so for the BSRT3, our activities, so we have the phase 2 of the internship qualifying exam that would start next week for 2 weeks yan. And of course, our final defense in line. I hope you're working with your thesis. And of course, our next webinar that will be on May 4th, 2024. And after which, we will be collecting your webinar portfolio. The deadline will be on May 10th, 2024. And before that, you have your grand case presentation for the subject radiation therapy. So I'm also inviting everyone here, not only from the UEP. If you have time, you can attend to our grand case presentation happening on May 9th, 2024. So the students here are mga tumatambay lang. Hindi sila masyadong busy. So So ayun, so yun lang naman yung mga announcements natin. So again, keep posted for our announcements in different platforms, either in Google Classroom or in our page, the UEP Radtech. And shout out sa aming mga followers sa UEP Radtech page. So we have 4,800 plus followers. Thank you so much for being updated with our page. So thank you so much. Yun lang naman, Oreo.
Thank you, sir. As we come to the end of today's webinar, we would like to express our sincere thanks to the dedicated BSRT faculty members, students, and especially to our guest speakers. We appreciate your enthusiastic participation and active engagement, which have made this webinar a success. Of course, this event won't be possible without the support of our UEP administration through our President, Dr. Cherry I. Ultra, and our College Dean, Dr. Sarah B. Dilorino. Thank you everyone for being part of this memorable gathering. We hope to see you soon again, and remember to never stop learning because life never stops teaching. Goodbye everyone, and have a nice day. Reminder to all participants, please do not leave yet the Zoom meeting because you will fill the evaluation form for the issuance of e-certificate of participation. The link will be available in the chat box for Zoom and FB Live participants. Thank you.
Thank you so much, everyone. Thank you so much, everyone. Have a happy lunch.
Oh, kalma. Oh, kalma. Baby, kalma.
Okay, namingo. Pure kayo, Ipi.
Huwag mo naman akong bigyan ng dahilan para tapihan ka.
Mabawi na lang ako next time.
Kalma.
Thank you, officers.
Teka bang kumalma. Isang ngiti pa sa kilalapitan talaga kita. At habang tumatama yung vodka, mas lalo ka pang tumitindi. Huwag mo naman ang asa ng sobra, hindi ako makakaindi. At wala akong pakialam kung merong makakita, di na mangyayari muli. Di ako papayag nang di ka mauuwi. Pag nagpalagabog na si ate, sobrang swabe, ang salbahe. Tignan mo siya kung paano gumiling, para panlaban ang atake. At malakang na lang ang kailangan, tapos na kagad ang usapan. Man, I wanna see her booty go left cheek, right cheek. I wanna see her booty go Morena!
Hinahanap ko Paborito ko nga po na nayalabi mo. Are you down? Let's go. Correra matro. Ikaw ay movie, there's something I wanna show. Daming sumubok sa akin, pero ikaw ang napiling matikman. Sa lakas ng musika, tumugtog-tog, ikaw lang gustong masayawan. Ayaw kitang katabi, gusto kitang ibabaw. Nahigit ang bawi, di mo na ako mabitaw. Lakas ng lupit, kaya di mo maiwasan. Gusto ko marinig sa bibig mo aking pangalan. Karen Jane, Phyllis, madami ng iba pero hindi ikaw sila. Tinatalong, baby, grabe hanggang gagawang hinaglaban.
Pag nagpalagabog na si ate, sobrang swabe, ang salbahe. Tignan mo siya kung paano gumiling, para palaban ang atake. At malakang na lang ang kailangan, tapos na kagad ang usapan. Man, I wanna see her booty go left cheek, right cheek. I wanna see her booty go Baby girl, just move if you wanna, shake if you wanna. Sige, alugin mo, do what you wanna. Twerk if you wanna, kabog lahat ng nakatingin. Shawty, why you so fine? Did you got it from your mama? Ass like coco, taas hanggang baba, ha? Alam ko naman, palabang ka talaga, ha? Hindi ko titigilan yan hanggang umaga. Pag nagpalagabog na si ate, sobrang swabe, ang salbahe. Tignan mo siya kung paano gumiling, para panlaban ang atake. At malakang na lang ang kailangan, tapos na kagad ang usapan. Man, I wanna see her booty go left cheek, right cheek. I wanna see her booty go.
Stop recording na ada, Jasmine, stop recording tapos end na natin ang meeting. So thank you so much again. You are free to yeah, you are now free to leave may nasulod po. You are now free to leave our Google Meet,
Yes, sir. Thank you,
our
sir.
Zoom. Thank you.